papilloma, human papilloma virus. Papilloma virus, HPV. You should know that the primary reservoir of this is men, okay? Primary reservoir. There are several serotypes, okay? And mostly women will get it through sexual intercourse, okay? Mostly, okay? The serotypes are we have 6, 11, 16, 18, 31, 33, 45, 52, 58. These are the most common serotypes that exist, okay? And out of all these, there are other ones, okay? Out of all these, HPV serotype 16 is the most carcinogenic. It's the most carcinogenic. It means that carcinogenic serotype. It means that it is this HPV that can induce cancer of the cervix the most. And by what percentage? You should know that HPV 16 induces single-handedly about 50% of all cervical cancer cases. Okay, can induce single-handedly. Okay, are we getting that? Are we following? But if you take HPV 16 and 18 together, they can induce 70% of what? Cervical cancers. So the most common HPV serotype, or the most carcinogenic is what? HPV 16, then followed by the rest. But if you take HPV 16 and 18 together, they will cause 70%. But if you take HPV 16 alone, they will cause what? 50% of what? Cervical cancer cases. Is that clear? Yes. Please, are we getting that? Yes. Okay. Is that? Yeah, we are not done with the ones that cause cancer. We are talking about the most common ones, okay? The most common. Now, the carcinogenic, in general, the carcinogenic serotypes. The carcinogenic serotypes. Carcinogenic serotypes. 6 and 11 is not part. So we have HPV 16, 16, 18. We know that this is the most common. We know 16, 18, 31, 33, 45, 52, 58. But we can add other serotypes, which can also cause cervical cancer. Okay, we can add 51. Okay, you can add 35, 39, 50. Sorry, let's put it this way: 51, 56, 35, 39. This can also be added. They can also cause what? Cervical cancer. Please, are we taking note of that? They can also induce what? Cancer of the cervix. So these are the carcinogenic. They cause cancer. HPV 6 and 11, they will cause what? Genital what? They will induce genital what? Okay? They will cause genital what? 6 and 11 will cause genital what? Please, is that clear? Is that clear to you? They will cause what? Genital what? 6 and 11, genital what? But if you come to 16, most carcinogenic. 18, carcinogenic. 31, 33, 35, 39, 51, 52, 58, 50, even 56. Okay? So the carcinogenic types, there are a lot. But out of all of them, HPV 16 is the most carcinogenic type. Is that clear? So if they are going to bring a question on cervical cancer, please look out for the multi-parity. Okay? And sometimes they will say multiple sexual partner. Are we getting that? Are we following? Yes. And even the age, we'll talk about that very soon. Okay. It doesn't mean that with different men per se. The same. I mean, it means that if you are getting pregnant, it means that you are having sexual intercourse frequently. Are you getting that? And the frequency of sexual intercourse in couples, which may not be loyal to each other, or which may have other interests outside the zone of coupling. may predispose to. Yes. Please, do we get this? All right, let's talk about the HPV vaccines. HPV vaccines, human papilloma virus vaccines. Yes, please.
If the man is there with a work, most women get it from men. So how do the men get it? How do they get it?
How did they?
How are they infected?
They also get it from other women. No, it probably. When we say reservoir, it doesn't mean that. Okay, it doesn't mean that HPV does not only affect women. It does not only affect human beings. Okay, it can affect other stuff as well. But they will not cause. I mean, it's in women that you have the cervical cancer happening. Okay, the primary reservoir, it can be in women as well. Okay, but the primary reservoir is what? Yes. It tells you that in men you have some genetic mutations or genetic predisposition which allows for HPV to multiply in them from the external environment. You can get HPV from the external, but in men it's kind of proliferates easier as compared to women. But can also proliferate in women as well, but the primary source will be men. It's more common in men than the women. Yes.
So if men are the primary reservoir, do they get some form of cancer?
They can get, they can have genital cancers. Yes, they can have genital cancers. But in women, cervical, okay? But sometimes even skin cancers. Now let's talk about HPV vaccines. Okay, HPV vaccines. Okay, there has been an improvement, or there has been a way forward for the vaccines. Initially, there was this one called Cervarix. Cervarix is more of a bivalent. Okay, it's a bivalent vaccine. Means that it can protect against only 2. Okay, so it goes against what? HPV 16 and 18. These are the lethal ones. Okay. We have what we call Gardasil. Gardasil 4. Gardasil 4 is more like a tetra. Okay, it's a tetravalent vaccine, meaning that it can protect against 4 of the serotypes, against HPV 6, 11, 16, 18. Then the new one is Gardasil 9, which is a nonavalent. Okay, a nonavalent vaccine. Nonavalent, meaning it can guide against the HPV 6, 11, 16, 18, 31, 33, 45, 52, 58. Is that clear? Please, is that clear to you? So these are the HPV vaccines: Cervarix, Gardasil 4, Gardasil 9. Gardasil 4 meaning that it protects against 4 serotypes of HPV 6, 11, 16, 18. Gardasil 9 meaning against 9 serotypes of the HPV. HPV, that will be HPV 6, 11, 16, 18, 31, 33, 45, 52, 58. Please, are we clear on that? Are we clear? Okay, let's move on. Now, the next thing we want to talk about is the histological types of cervical cancer and the pathological types. Then after that, we'll look at the methods of spread. Okay?
Does it mean that there are some the rest?
Of course. Can you see it makes sense? Because if you can protect against a lot, and it's so obvious, but the availability. I mean, once it's available, why not? Yes. Don't worry. You are shooting fast. Don't worry, we'll get there. Don't worry at all.
Because in the developed countries, once after menarche, they are given the vaccine.
Don't worry, we'll get there. We'll talk about that. Don't worry. It means you should be listening to either culture or Bob Marley. Right? Alright. Okay. Let's talk about the histological types of cervical cancer. So the histological types, it means that we are looking at the cell type specifically. You can think of one. Squamous cell carcinoma is the most common. Squamous cell carcinoma. Okay. We are looking at 90 to 95% of cases will be what? Squamous cell carcinoma. And next one is adenocarcinoma. Means it's less. How many glands are we having there? That so less 5 to 10%. Okay, 5 to 10%. Then the next one is mixed. It's mixed. Mean combination of, so you can have what? A squamous cell carcinoma with what? Glassy cell, or you have clear cell or glassy cell carcinoma. Those are like a mixture. Okay. Or we have a squamous cell with what? Adenocarcinoma. Okay. That's a mix. Now let's talk about the pathological types. The pathological types of cervical cancer. So the pathological types are going to be what you are going to be seeing, okay? Mostly. We have what we call the endophytic. Okay, endophytic. Okay. Or what we call ulcerative growth. Endophytic. I mean, when you look in between, if you look inside the cervix, you are going to see ulcerations. Or it's like more like going inward, endophytic, okay? Then the second type we call it exophytic. If something is exophytic, it means that it's growing outward. Spread, direct extension or spread. Okay, direct extension. Okay, direct extension. Now look, this is your uterus, okay? This is the cervix, this is the uterus, the body, the fundus, right? So if there's cervical cancer here, look at it. It will be spreading towards the adjacent, contiguous structures. So it will go like this, okay? It will go like this into the endometrium. You know the fallopian tube are at the side, right? Are we getting that? Excuse my drawing. It's just a depiction of, okay, in that order. So it will spread to the endometrium, spread through to the fallopian tubes. Are we getting that? Are we getting that? And also it will go to the lower 1/3. Okay? So we'll say that it spreads to the endometrium. Direct extension spreads to the endometrium, the fallopian tubes, the lower 1/3 of the vagina, and what else can you spread to? Which other adjacent structure is there? Huh? The well, it could, yes, it can spread to. Once it comes out from the fallopian tube, yes, it can involve those structures. The bladder.
Ovaries.
The ovary too, not really. So it spreads to the endometrium, the fallopian tubes, the lower 1/3 of the vagina. Okay, lower 1/3 of the vagina. Okay. Lower third of the vagina. Okay. Okay, let's move on. The next spread is lymphatic spread. So this one, it means that we are going to have spread to it, the obturator, spread involving the obturator. So it involves, okay, the obturator lymph nodes, okay. You think of the femoral lymph nodes, think of the internal iliac lymph nodes, the external iliac lymph nodes. What else? The common iliac lymph nodes. What else do you think of? The para-aortic lymph nodes, lymph nodes. Okay. Then the third one is hematogenous. It's rare. It's not so common. Okay. Hematogenous spread. Rare, not so common. Okay. Rare, not so common. Okay. Rare, not so common. Now, the next thing we want to talk about is the clinical presentation. Let's talk about the clinical presentation. Clinical presentation. So there are two forms of clinical presentation. Okay. There are two forms of clinical presentation. Clinical presentation. So for the clinical, they could come asymptomatic. Okay. Then they could also come symptomatic. Are we getting that? You should take note that cervical cancer has a bimodal peak. It has a bimodal distribution. It has two modes or two peak of what? Incidence. Okay. It has a bimodal distribution. It has a bimodal distribution. What is a mode? You know what it means? The item with what? There was most occurring item or item with the highest frequency is what we call mode. Okay, that's what we determine by mode. So as a bimodal distribution, that is at 35 years and at 50 to what? 55 years. Okay. At 35 years and at what? 50 to 55 years. Meaning that, okay. And it tells you that when a patient acquires the HPV, it will take about 10 years for cervical cancer to develop, because you have to progress through the pre-malignant stage and all that. Okay, to take about 10 years. Okay, so it has a bimodal distribution, meaning that it has two peaks of incidence of peak age of incidence. It has to 35, 50 to 55 years. Now for the presentation, they will come with vaginal bleeding on contact, vaginal bleeding on contact. An example of that, postcoital what? Bleeding. So if you have a patient having sexual intercourse and bleeding, okay, unnecessarily, or bleeding unexpected, or bleeding that gives a suspicion that you need to check for what? Cervical cancer. You need to screen for cervical cancer. Okay. The next one, malodorous vaginal discharge. So in a clinical vignette, you will see an age. You see an age in that category: 45-year-old, or 40-year-old, or 50-year-old, or 46-year-old present with abnormal vaginal bleeding, or malodorous vaginal discharge, and it has a high parity order. Okay, or you can say it's a grand multiparous woman present with abnormal vaginal bleeding and what? Malodorous vaginal discharge. Okay, 45-year-old presenting with that. So malodorous vaginal discharge. Yes, please.
Number of years after menopause is already relevant. Number of years after menopause is relevant.
Yes, it could be relevant, meaning that if the patient acquires it, so you look at the threshold where he's acquiring for, it will take 10 years. So if the patient acquires, yes, so if the patient acquires before menopause, 10 years after that, yes, they may develop cervical cancer. Okay. So they have malodorous vaginal discharge. Okay, they can also come with what? Symptoms of UTI. We know the symptoms of UTI, they're irritative and they're what? Obstructive. And do you know why there will be symptoms? If there is bladder involvement, if there is what? Bladder involvement, yes, they will have what? Those irritative, or if there's a mass effect, they would have what? The obstructive symptoms. Okay? They can also come with erectile pain. Why would they come with erectile pain? If there is what? Rectal involvement. Rectal involvement. Okay? They can also come with pedal edema. Pedal edema, if there is what? Vascular involvement, or if, yes, when there's a vascular involvement, yes, they could develop what? A pedal edema, because there's going to be obstruction to the flow of what? Venous blood, leading to congestion, and that would give rise to the pedal edema. Okay. They could also present with intermenstrual bleeding, intermenstrual bleeding, intermenstrual bleeding, intermenstrual bleeding. Okay, intermenstrual bleeding. Yes, what else can they present with? Well, that one will be more of, when we get to the complication. They can also come with weight loss as part of cancers. Okay, weight loss. Okay, weight loss. Weight loss. Okay, so these pelvic pain, pelvic pain, erectile pain. Okay, yes.
Dyspareunia. Dyspareunia.
Dyspareunia, not really. It's not a classical.
General symptoms of anemia.
General symptoms of anemia. It's possible if it has spread to the bone marrow and all that, but it's not so common with them. Okay, not so common. Okay. All right. Let's move on. Now, the next thing we are going to talk about is the screening criteria for cervical cancer. Then after that, we'll look at methods of screening for cervical cancer in Ghana, in our country. Then we'll look at the investigations that we should do in case we are able to confirm cervical cancer. What is the difference between a screening test and a diagnostic test? Yes, anyone?